All right, everybody. We're back at it. So here we are going to talk about shin splints. And I cannot stand this as a diagnosis. If I have a doctor or therapist who gives me a diagnosis of shin splints, it tells me they probably do not know their anatomy or understand conditions around the front. This is something around the front of the leg, I should say. This is something that a running coach would typically give. Oh, you've got shin splints. We can do better than shin splints. Okay. So let's go here and look at this. Shin splints defined as a non-diagnostic term for exercise-induced anterior leg pain. Your misdiagnosis or failure to call it the correct anatomical condition that it is may delay healing for this person and getting the right actual therapy for them as well. So we have an anterior compartment syndrome is one of our differentials. Tibial stress fracture is another one. Even something like a muscle strain, tibialis anterior, or any muscles in the anterior compartment could also be classified as shin splints. Okay, we can do better. So call it what it is, identify the tissue specific damage that's taking place for this person so you can give specific treatment options around that condition. I cannot stress this enough. All right, so tibialis anterior strain, what happens right there? You can pick any of the muscles in the anterior compartment, really, and you're looking at the DOMs typically. So what has the person done? Mainly pain with excessive eccentric loading, an overabundant heel strike running downhill, or overstriding, so the heel's hitting the ground fairly hard. You can be looking at a medial tibial stress syndrome as well, where you're actually getting a tibialis posterior, flexor hallucis longus, or extensor digitorum longus issue, or even a soleus strain. Mainly seen this now with toe off. And because you've been more specific, you can already give more specific recommendations if you can identify these pathologies. It occurs during physical activity, running, secondary to repetitive microtrauma, and overuse of the fascia. And the muscles attaching, typically tibialis anterior. Recent studies have supported medial tibial stress syndrome is not an inflammatory process of the periosteum, but instead a stress reaction of the bone. So please be aware of that from Tweed et al. So medial tibial stress reaction and grading, that's what we're going to run down here. I'll do the differentials in a little bit, but I just want to make sure that we understand this. So pain on palpation of the involved tibial crest, no symptoms during activity or running, okay? Discomfort after running, but not during, is going to be a grade 2. Grade 3, pain with running and residual pain occurring there as well. Becomes so severe that the person is not enjoying their training routine. Then you can get into symptomatic with walking as it gets more substantial. And by the time people get to here, they are wanting to take breaks. They are likely seeking medical help at this time. So demographics, who gets this? 12 to 18% of running injuries. This is a very common condition. Peak athletic years, 18 to 50 typically. Gender, slightly greater in females. If you do see it in women, you'll often see it associated with the female athletic triad. So look for that amenorrhea, osteoporosis, and you can say an eating disorder or malabsorption disorder where they're not getting the nutrients in. Remember what is happening here in the female athletic triad is their body is so stressed that it's basically saying you cannot have kids right now and they become amenorrheic, right? Risk factors, multifactorial, depending on the cause. Shin splints, too generic, doesn't help us. So you could have ankle and foot biomechanical issues that are taking place. Lack of training ability could be there, or training errors we can see. Running on hard surfaces without giving the body time to adapt. Improper footwear or shock absorption. These are going to be some of the key items that we look at. Muscle weakness and imbalance could be there potentially. Leg length, pelvic malalignments could be there, or pelvic anomalies where you have one side of a pelvis larger than another, and therefore you have an unequal stride. That's controversial, so just be aware I wouldn't take that as the full be all and end all. Tibial torsion, where you've got anatomical variations of internal and external rotation, or anteversion and retroversion. Increased Q angle in women has been associated with increased risk of shin splints, and low calcium intake or absorption, back to that dietary issue. So what do we get? Gradual onset of dull, achy anterior shin pain that increases with exercise intensity. It is a repetitive microtrauma that causes it. Pain is worse with activity and direct palpation, better with rest and mild stretching. So the person already knows how to treat it. They're going to have to do some activity modification, but we'll get into that in a little bit. Usually you have no visible signs of this. Swelling may be noted, but hardly ever. Tenderness over the posteromedial tibia, usually the medial and distal half. Motion evaluation may be within normal limits, or if you're pulling on the damaged area with the muscle attachment, it might be mildly painful. And neurovascular should be within normal limits because this will help us rule out a compartment syndrome. And of course, a compartment syndrome is where you increase the pressure. I'm going to talk about an anterior compartment syndrome, although it could happen in any of the compartments. There is a separate video you can watch on that. But you would lose the tibialis anterior, not tibialis anterior, dorsal pedal pulse if you have an anterior compartment syndrome. So what are we looking at for differentials? Number one, tibial stress fracture. So what happens here? Somebody has repetitive microtrauma where their body has not had time to adapt. My good buddy Ryan, Dr. Ryan down in Portland, Oregon there, he is about an inch shorter than me, but weighs about 220, 230 lean. Like this guy is jacked. He is huge. He is strong. And my good buddy Ryan decided he was going to do the hood to coast run, which is where you run. I think it's over 200 miles. You do it in sections where you have multiple players on your team that are running with you. So you run for a bit, then somebody else runs, but he had not been training enough and he developed tibial stress fractures bilaterally because he's a heavy, strong guy and his tibias were not used to that kind of pounding. And therefore the bone had repetitive microtrauma. It resulted in these small microfractures and he had shin pain for about 2 to 3 weeks that came on. He did not want to load heavy, run, or do anything. So it would be a tibial stress fracture. And it lasted for a little bit longer than that, from probably more like 4 or 5 weeks, but a fracture takes longer to heal. And it's a mild, stable fracture, so it doesn't require any casting or anything like that. But give the correct diagnosis to that patient so they understand the process. Educate and empower them. The next thing is going to be a chronic exertional compartment syndrome. This one, the patient is usually going to say, it feels like the front of my leg is going to explode, and they can push on the front of their tibia and they'll feel the bone there, and then they'll go lateral over the anterior compartment and it will feel very full as well. So extreme feeling of fullness, or aware of that. Yeah. What else do you have? And then you have your standard muscle strains that can be there as well. So that'll be your typical DOMS. So that can be a tendonitis or muscle strain where the person is sore for 24 to 48 hours, but then it goes away relatively quickly. Herniation of the muscle. I've seen this rarely as well, where you can have the muscles herniate out from their fascial membranes. Pretty rare, but it can happen. You can be looking at a lumbar radiculopathy. And again, I would refer you to that video to go ahead and look at it. But this one's pretty obvious. They'll often have low back pain, shooting pain that is worse with coughing, sneezing, or straining if there's disc involvement. And they'll have marked neurologic weakness potentially as the case progresses. What else? Fascial deficit. Again, it could be some fascial tightness or a herniation as well. Deep vein thrombosis. This one's a little bit trickier, but what you should be looking for is more calf or gastroc soleus type pain. And we'll have a separate video on that you can look at. And the same with intermittent claudication. This is usually a bilateral condition right here. And what happens is this is our typically geriatric patient population, and they get the numbness and tingling or weakness or inability to walk over a certain distance, and mainly posterior calf typically, although it can be anterior as well. Bilateral weakness though. All right, special tests. There's nothing specific for this. Mainly rule in and rule out other pathologies. So trying to figure out what else is going on. If it is a tibial stress fracture, you can actually do a fracture screen and flex the bone. So I'll usually take the tibia. I'll give you an example of this once we get into it. Well, I'll give it right now here too. So I had a patient come in and she was the female athletic triad. She was all of like 28 years old. She wasn't eating very well, amenorrheic, and doing marathon running and powerlifting at the same time. And she had chronic hip pain, and I went through and I tried to do my assessment. The closest I could get to was she had some kind of capsulitis around there. She goes to run the Victoria Marathon, 10 kilometers in, she collapsed, and she goes to the ER at UBC, University of British Columbia. And one of the docs there does a test that I'd never seen before. And he called it a fulcrum test, basically. And what he did was he put her femur on the edge of the table and then pushed down on the distal end of her knee, and it caused hip pain. That is a test where you're taking the femur and using it as a fulcrum and then bending it just a little bit to challenge the bone to see if it causes pain. You can do the same thing with the tibia. What I'll usually do is take the person's tibia, put it off the edge of the table, and then I'll push down on it and see if that little flex of the bone causes pain, and it would increase my likelihood of tibial stress fracture. Diagnostic imaging may also be warranted. A radionucleotide bone scan can show you increase activity in the area of the osteoblasts. So that could be a good test that you could perform. X-ray, only if you're going to rule out a more obvious fracture. And then MRI might be indicated. Ultrasound also might be a good choice as well to look for more soft tissue injuries. Management. It is foundational that you give the correct diagnosis. Have I mentioned shin splints is a crap diagnosis. Do not say that ever, okay? So depending on the cause, then you're going to be giving specific treatments based on that. But generally, if you miss a compartment syndrome, an acute compartment syndrome, and I'll talk about a story on that one once we get into it as a specific video. Again, go look at the video. You can be missing a condition that has significant negative outcomes on this person's life by not getting the appropriate medical attention early on. What would I do in general, though? Of course, our basic education, empowerment, and exercises. To tolerance, of course, activity modification for at least 1 to 2 weeks to make sure that they can tolerate activity. If it hurts, don't do it, and make it that simple. Lower training intensity or switch activities from running and impact loads to biking or swimming loads that are a little bit less that can still maintain cardiovascular function. Massage therapy is a great choice. Most patients and clients will respond extremely well to massage therapy. You might do some pin and stretch as well. A lot of people really like that. Osseous mobs and manips can offer benefit into the foot, into the ankle, as well into the knee, hip, SI joints, low back. All that's going to make it offer potential benefit. Ultrasound can be good, or microcurrent to increase local blood flow and promote healing if there is some more osseous damage. You can look at acupuncture and diet and botanicals that will support the healing processes. Make sure that they have a good nutritional support and potentially even a low anti-inflammatory diet. Surgery is rarely indicated only if you have a more significant injury, such as an acute compartment syndrome or a fracture that is a non-union fracture. Okay. Yeah, recurrence rates, you can look at it right there, not a big deal. Frequency leaves the patient with strength deficits. Be aware of that, especially if they have a fasciotomy performed. They will have strength deficits in that area. Okay, follow up. Rehab program, focus on modifying activities and building tolerance to the repetitive load. So stretching and strengthening exercises, considering starting with low impact activities and then gradually increasing. And here I mentioned the biking and swimming again. Patient education on proper footwear. Running shoes lose more than 60% of their shock absorption after that 500 kilometers. If they are an elite level athlete, they are probably changing their shoes on a regular basis. Treat a number of triathletes and marathon runners, and they are going through shoes like crazy. Look to run on softer surfaces or even progressing towards barefoot running potentially as well. There's lots of good research around that. Proper warm-up prior to activity, and then prognosis. Or even if this barefoot running, I would say even a minimalist shoe, especially if you're running on softer surfaces. Prognosis varies depending on the actual condition, but a stress syndrome responds extremely well to conservative care. Really, it's rest that does most of the benefit, and that's supporting the body's natural healing abilities here. Medical legal, misdiagnosis of a compartment syndrome and the surgical effects may have medical legal ramifications. You definitely want to have the correct diagnosis. Do not just say shin splints. All right. And then of course, any activity we can do. Some people like foam rolling, balance exercises, wobble board, rocker board, whatever you want, even lunges, standing on one foot, you name it, anything that you can do to increase tolerance to load and improve proprioceptive ability and graded exercise exposure is going to be a win. Okay. So if it hurts, don't do it. Modify the activity. Educate your patient, empower them through the process, give them the appropriate exercises, and then our manual therapies can come in to give our ultimate treatment options for our clients and patients. Thank you very much for your time, and I will see you on the next video.